Hello, I'm Lucy. I work at Women's Health Tasmania, and for this episode, we're bringing you something a little bit different from the regular episodes. As part of our trans and gender diverse menopause project, we chatted with local legend Dr. Miranda, a GP who works in trans healthcare. In no less than 15 minutes, Dr. Miranda gives us answers to the big questions about trans and gender diverse people's healthcare when it comes to menopause and the impacts of gender affirming treatments. This conversation gives you the basics, the context, and it points you in the direction of where to go if you want to do this work with nuance.
So my name's Miranda. My pronouns are she and her, and I'm a GP here in Nipaluna, Hobart.
Can you tell us, how do you see menopause or perimenopause show up for your trans patients most often?
Yeah, look, it really depends on the hormonal experiences of the person. So with my patients who are already on estrogen therapy, we'll see menopausal symptoms show up if we ever have to stop that therapy for medical reasons, or if people choose to stop taking their estrogen therapy at some point in their lifetime. That's obviously going to be dependent on if we still have testosterone blockers in place, or if somebody's had an oophorectomy, in terms of whether testosterone comes back as the dominant hormone, which can sometimes help take away some of those menopausal symptoms. But that's how we see it in our patients who are taking estrogen. Whereas our patients who are taking testosterone, we often see menopause-like symptoms when we're starting testosterone, because we'll get a drop in people's estrogen levels, particularly if we do a slow start or a slow taper with our testosterone levels, or are maintaining a lower level long term. That more gradual decline in estrogen levels in people's bodies can give us some of those menopausal symptoms. And then in our sort of non-binary patients or trans and gender diverse people who don't want to be on hormone therapy and have estrogen as their endogenous hormone, so the hormones that they were born with, then whenever those hormone levels naturally are going to decrease in their lifetime, they're going to experience a menopause just like anyone else who is born with estrogen in their body.
So they might be going through that at like midlife, or maybe if they had some kind of surgery for another reason.
That's right. Yeah. So roughly midlife on average, and then earlier if there's medical or surgical reasons for that.
How would you characterize the level of knowledge in this space of trans people and menopause?
Very poor. It's very poor both amongst clinicians, but also in community. Like, there's just not a lot of conversations around this space, and there's not a lot of medical evidence. The trans population is only 1 to 3% of the population of Australia, and so that's not a lot of people to help facilitate information and knowledge in that space. And, we are getting more and more information and research coming out. And the Trans Health Research Group is doing a lot of medical-based research, but there's just not a lot of information about that overlap. And because it is so different for each type of gender experience, it's not going to be a universal sort of language that we can use or set of information or guidelines. Like, it's going to be very tailored and specific to the person in front of you.
So it's all about really that individual person's experience of hormones?
Yeah. That's actually probably a good way to put it. It has more to do with what that particular person's hormones are doing at that particular moment in time, and how those shifts might be occurring from a balance of estrogen and testosterone in the body.
Some people who are trans and gender diverse also live with neurodiversity. Can you run us through what issues this might present for patients, both in terms of what their health might look like, but also how they might take up or access healthcare?
Yeah, so neurodiversity is inclusive of sort of our ADHD and autism spectrum disorder diagnoses. And what we tend to see clinically in this patient group is a much higher sensitivity to hormonal shifts in the body. And we'll see that in things like PMDD or PMS symptoms. That's premenstrual dysphoric disorder or premenstrual syndrome. In people during their cycles, and sensitivity around things like contraceptive pills and how people's bodies respond to those. And so we do see a lot more sensitivity than when we're experiencing menopause and what that's going to present as for patients. And certainly in our ADHD group of patients who are experiencing menopause, we get a lot more of those cognitive impacts when we start to lose estrogen. So a lot more brain fog, fatigue, slow processing, and slow thinking. We tend to see a lot more burnout of people who have ADHD during those peri and menopausal times of life. And, there is definitely an overlap of our neurodiversity and trans and gender diverse community. And so when you're looking at two communities with quite unique experiences of perimenopause and menopause, you're then combining two levels of uniqueness that then needs much more specialized and tailored care for somebody who can understand the nuance of that overlap. It might take a little trial and error for some patients, and you're not going to get it right the first time, and being really open and honest about that with the people who are in front of you, because when you're balancing a really sensitive hormone profile with the challenges that come with perimenopause and menopause, and it can be really difficult when it's not right the first time, and sometimes it does take a little bit of figuring it out for what works best for that particular person and their biochemistry.
When it comes to the perimenopause space and trans folk, what are you mindful of as a GP who's aiming to work in a trauma-informed way?
Being a trauma-informed clinician is recognizing that you're really trying to take time to listen to the person in front of you. Particularly with the trans and gender diverse community, there's a really, really high level of experience of what we call healthcare trauma, which is when people have had poor or discrimination-based experiences within the healthcare system. And when we're working in that healthcare system that has already caused harm, the way that we need to show up for people looks a little bit different and sometimes can take a little bit more time, and balancing where that person's capacity is at and what they're ready to take on board from a healthcare advice perspective today versus maybe what they're ready to take on board in a few weeks. And that can shift and change, and sometimes it means starting slow. Sometimes it means somebody wants everything all at once, and sort of meeting people where they're at in terms of what they're trying to access and get support for at that time and point within that healthcare system. It can take quite a long time to build rapport with somebody who has experienced a lot of healthcare trauma, and that's not always a linear process or a linear experience. And some of my patients, we sort of bond right away and can kind of build a really great rapport fairly quickly. And other people, it's taken me years of really gentle and gradual conversations and introducing things slowly and making sure that person feels really supported, and creatively finding ways to support people's health when traditional sort of Western models of medicine don't work as well.
Can you tell us a little bit about the intersection between GPs who specialise in menopause care and GPs who work in gender-affirming healthcare?
My area of sort of knowledge in Tasmania is within the trans and gender diverse community and providing gender-affirming care, which includes hormone therapy. And that just means I'm really comfortable working and tailoring their hormone experiences to how they're going and what they want and what their goals are. And I have a lot more flexibility and knowledge and understanding in how those different hormone shifts work and how they're going to be affecting people's cognition and thinking and emotions and relationships. And so when I work in menopause care, I also then now have a lot more flexibility in that, and I am quite comfortable with hormones and hormone therapy and prescribing. And so I think it's actually made me a lot better at menopause care, because the training that we get for perimenopause and menopause is variable through our medical school and training programs, and I think that's evidenced by some of the narratives that are happening around menopause care at the moment and some of the things that patients have noticed in the knowledge base of clinicians. But working with trans and gender diverse people has made me a lot better at it.
What can a GP do to support trans patients as they age? Are there particular screenings for cancer or heart health that trans patients need when they're on hormones long term?
Yeah, so our cancer screening guidelines in Australia are actually quite clear, which is really great. And we do shift and change some of the screenings that we do, but it's going to be based on the body parts and anatomy that people have. And so if somebody has breast tissue, they're going to need to get mammograms per our screening guidelines. That's for sure getting mammograms after the age of 50, but they are offered through like Breast Screen Tasmania from the age of 40 for people. And for a trans and gender diverse community, if people have been on estrogen therapy, so feminizing hormone therapy for at least 5 years, they qualify for those same breast cancer screenings that the rest of the population does. And then we're still thinking about our other cancer screenings like cervical screening. So if patients have a cervix, they do need to make sure that that's getting screened. That does come in with some nuances because if people have been able to change their birth gender marker on their Medicare, they might not get those standardized reminders from the government around things like cervical cancer screening. And so it's important that the GPs are aware and kind of paying attention and keeping an eye on that for people because they're not going to get the same reminder systems coming in. And then, the 50s age range is when we start to see a lot more cardiovascular disease. And so we have really great guidelines around screening and monitoring for cardiovascular risk. And we would just apply that same lens to our trans and gender diverse community, recognizing any other risk factors that they might have based on their medical conditions and medical history already.
How would you encourage a GP who is thinking about doing this work, and where should they start?
It's a really rewarding area of healthcare. Certainly, you end up with a doctor-patient relationship with people that is a little bit more unique than some of the other spaces that we work in. There's heaps of education available at the moment. From a menopause and perimenopause perspective, there's education resources on the RACGP website. They've just put out a new set of they're called check cases on menopause. There's education through Primary Health Tasmania and a few private organizations that are offering regular menopause education. From a trans and gender diverse perspective and learning about gender affirming care, AusPath, which is the Australian Professional Association for Transgender Health, has a standards of care that's just been updated and is really excellent. It's a sort of step-by-step guide to follow to be able to provide gender affirming care to patients. There's also information through the RACGP Special Interest Group, and there's a few clinician-based Facebook pages that are available for doctors to be able to ask and get resources and sort of talk about complex cases. So one of those is the GPDU Gender Affirming Care Facebook page, and then we have a local one in Tasmania as well called Gender Affirming Healthcare Tasmania, and that's a multidisciplinary one. So we do have a lot of allied health in that particular Facebook group as well. GPs as a whole, we are working really hard and quite overburdened on a daily basis. And working within these niche communities can sometimes provide a bit more sustainability in the way that we're actually showing up to work, because you're working with a group of people that is grateful to have somebody in front of them who knows what's going on and who understands their healthcare. And that can a lot of times make it a lot easier to show up to work every day when we're in a realm where we're constantly on the verge of burnout, right? And so I find that to be really helpful and is a way to make sure that I help to maintain my sustainability in this job.
Okay, folks, that's a wrap. Thank you so much for listening to this episode of Speaking of Health. And hey, sharing is caring. So if you know someone who should listen to this, share the episode with them. Might even make their day. Women's Health Tasmania made these episodes about menopause as part of our trans and gender diverse menopause project. where we worked with a trans and gender diverse advisory group and clinicians who know about trans healthcare. The work was funded by an LGBTIQA+ community grant through the Tasmanian Department of Premier and Cabinet. If you want to know more about the project, check out the show notes for links. This podcast is made in Lutruwita, Tasmania. Always was, always will be Aboriginal land.